Cardiovascular diseases is a general term for conditions affecting the heart or blood vessels. It's usually associated with a buildup of fatty deposits inside the arteries or the atherosclerosis and an increased risk of blood clots.
A congenital heart condition is a problem with the structure of the heart, which develops before a baby is born. The most common congenital conditions include a hole between two of the heart's chambers, septal defects, narrowing of the body's main artery, coarctation of the aorta, narrowing of the pulmonary valve stenosis. These affect almost 1 in 100 births in the UK. In most cases, a problem has occurred during the early development of the fetus. This could be due to a mistake in a gene, but in most cases there's no known cause. Most defects can be detected during pregnancy, but some are not found until a baby is born. Less serious conditions may not be spotted until much later. Symptoms in babies or toddlers can include a blue tinge to the skin, poor feeding, breathing problems, extreme tiredness, rapid heartbeat, excessive sweating, and chest pain. Treatment depends on the individual and the condition. Some only require regular medical checkups, but others may need medication or surgery. There is evidence that some congenital heart conditions can run in families. The BHF is funding research about this.
A healthy heart, as seen here, beats approximately 60 to 100 times a minute, providing oxygen-rich blood to the rest of the body. The lower left chamber of the heart, called the left ventricle, is the main pumping chamber. There are many different conditions that can lead to congestive heart failure, including a prior heart attack, high blood pressure, and coronary artery disease. Any of these can prevent the heart from efficiently pumping blood to the rest of the body. As a result, the heart may beat faster, and the ventricle may increase in size, becoming an even less effective pump. When the kidneys sense the reduced blood flow, they attempt to compensate by retaining more water and salt. This excess fluid retention often causes congestion in the tissues and results in swelling and an increased strain on an already weak heart. The progressive effect of the heart failing to properly circulate blood and congestion due to fluid retention is known as congestive heart failure.
Arrhythmias are the collective term for all sorts of disorders in which the normal rhythm of the heart is disturbed. Normally, the heart beats about 60 to 70 times a minute. When exercising, this may increase to 120 to 180 times a minute. The heart always contracts in an orderly way. The impulse that signals the heart to contract is given in the sinus node. First, the upper chambers contract. Then, with a slight delay, the impulse travels to the lower chambers, after which they contract. On several points during this process, something can go wrong, causing the heart to not contract correctly. If the sinus node sends out too many or too little impulses, the heart beats too fast or too slow. A heart rate that is too fast is called a tachycardia. A heart rate that is too slow is called a bradycardia. In case of the sick sinus syndrome, the sinus node alternates in working too fast and too slow. Heart block occurs if the impulses are not passed on correctly to the lower chambers of the heart. This causes a disruption of the balance between the contraction of the upper chambers and lower chambers. It can also happen that the heart muscle cells of the upper chambers or lower chambers completely ignore the sinus node. They spontaneously contract in a chaotic manner. This is called fibrillation. During fibrillation of the lower chambers, the circulation comes to a halt. No more blood is pumped through the body. This is a life-threatening situation. Some people may suffer from arrhythmias but don't have any complaints. The complaints that an arrhythmia causes depend on the type of arrhythmia you have. Some symptoms that often occur are palpitations, chest discomfort, dyspnea, shortness of breath, feelings of anxiety, and dizziness. Treatment of arrhythmias depends on the type and cause of the arrhythmia. Arrhythmias in the upper chambers are less dangerous than arrhythmias that originate from the lower chambers. Arrhythmias from the lower chambers can cause the circulation to come to a halt and require immediate medical assistance. An electrical shock is needed to get the heart back into action. Usually, arrhythmias can be effectively treated with medication. In case of fibrillation of the upper chambers, blood thinners are often prescribed to prevent blood clots to form in the upper chambers. These blood clots can cause a heart attack or stroke. If medication doesn't help sufficiently, it is sometimes necessary to implant a pacemaker or an implantable cardioverter defibrillator, ICD. A pacemaker regulates the rhythm of the heart if it's too slow. An ICD can deliver a shock when the heart starts to fibrillate.
This shows healthy blood flow through the different chambers of the heart. Blood flowing through healthy valves moves without restriction through the 4 chambers of the heart. There are 4 valves: the mitral valve between the left atrium and ventricle, the tricuspid valve between the right atrium and ventricle, the aortic valve, and the pulmonary valve. Each valve is made up of leaflets that separate fully to allow smooth blood flow and then close tightly together to prevent backflow. This ensures that the blood circulates in one direction. In some people, the body's autoimmune response to a group A streptococcal or gas infection causes inflammation. This is ARF and can include inflammation of the heart, which is called carditis. The heart valves may also become inflamed, which causes stretching and thickening of the valve leaflets. When the carditis resolves, some valve leaflets may remain scarred, stiff and immobile, or stretched. This is rheumatic heart disease. The valves predominantly affected in RHD are those on the left side of the heart, the mitral and aortic valves. There are 2 conditions of the heart valves in RHD: regurgitation and stenosis. With valvular regurgitation, the stretched leaflets have not regained shape and therefore do not close completely. This causes blood to leak backwards. Regurgitation is also referred to as insufficiency or a leaky valve. With valvular stenosis, the stretched leaflets have remained thickened and stiff, and the opening is narrowed, reducing the amount of blood that can flow through. If the narrowing is mild, the overall functioning of the heart may not be reduced. However, in severe stenosis, blood can back up and pool in the chambers, preventing adequate blood flow through the body. Blood pooling in the chambers has a greater tendency to clot, increasing the risk of a stroke or pulmonary embolism. Regurgitation usually happens early in the disease, stenosis later in the disease process. It is possible to have both stenosis and regurgitation in 1 or more heart valves at the same time. And valves that do not have smooth contours are more likely to become infected. As valve damage progresses, the heart has to work harder to circulate the right amount of blood through the body. In severe cases, the heart muscle enlarges and thickens, thereby losing elasticity and efficiency.
Myocardial infarction, commonly referred to as heart attack, is the sudden death of part of the heart muscle due to loss of blood flow. This occurs when one of the coronary arteries, the arteries that supply blood to the heart, is blocked. The blockage is commonly due to atherosclerosis, cholesterol plaques or fat deposits on the wall of blood vessels. As the plaque builds up, the vessel becomes narrow, restricting blood flow. Under stress, the plaque may rupture. This triggers formation of blood clot on top of the plaque, leading to complete blockage of blood flow. When this happens in the coronary artery, the downstream patch of the myocardium dies from lack of oxygen. Weakened heart muscle may disrupt electrical activity of the heart and subsequently cause cardiac arrest. Coronary angioplasty is a non-surgical procedure used to open narrowed or blocked coronary arteries. It can also be performed as an emergency treatment for myocardial infarction. The first part of the procedure is to localize the site of blockage. This part is called cardiac catheterization. A guiding catheter is inserted through the femoral artery at the groin and threaded all the way to the aorta. The tip of the catheter is placed at the beginning of the coronary artery to be investigated. A radio-opaque dye is injected through the catheter into the coronary artery. This enables real-time visualization of the artery using X-ray imaging. A narrowed part of an artery would appear as a bottleneck on an X-ray image. After the location of narrowed artery is identified, angioplasty can begin. A guide wire with a deflated balloon is inserted and pushed to the location of blockage. The balloon is inflated to crush the plaque. At the end of the procedure, the balloon is again deflated and removed together with all catheters and guide wire. In some cases, a stent is inserted together with the balloon, inflated, and left in place of the plaque to keep the artery open permanently.
Cardiovascular disease, or CVD, refers to a variety of problems with the heart or blood vessels, including heart attacks, heart failure, and stroke. Together, they are the #1 cause of death globally, estimated at nearly 18 million deaths in 2015 and rising. Initial symptoms such as unexplained chest pains or exhaustion after only moderate physical exertion are frequently ignored, and thus many patients are only treated after suffering a heart attack or stroke. The aim of the EU-funded project CISFASC was to use a systems medicine approach to better understand the development of CVD and to find so-called biomarkers for it. Researchers hope that by using a comprehensive collection of clinical and experimental data to generate computer models of the disease, they could identify novel molecular targets suitable for early disease prediction. In many cases, cardiovascular disease is caused by the chronic inflammatory condition atherosclerosis. Due to unhealthy eating habits and a lack of exercise, deposits of fat, cholesterol, and other substances present in the blood build up over many years inside the arteries. White blood cells are attracted, triggering an inflammatory process. Over time, the resulting plaques cause the arteries to narrow and harden, obstructing blood flow. However, not all patients appear to have stable plaques, which build up and eventually limit blood flow. Some patients suffer from unstable plaques, which pose an additional threat. Unstable plaques are prone to sudden rupture, which causes local blood clotting and may even completely block vessels. If this happens in the coronary artery, the heart may become starved of oxygen, resulting in the death of cardiac muscle cells and heart attack. Physical exercise and a healthy diet prevent all forms of CVD, while drinking and smoking are risk factors. As atherosclerosis progresses, patients are increasingly exhausted after physical exertion, while severe cases cannot participate in everyday activities, like walking uphill. Currently, clinicians do not fully understand why CVD progresses faster in some patients than in others. We know from studying tissue that unstable plaques have a thin fibrous cap over a large lipid core, while stable plaques have thick fibrous caps that prevent premature rupture. Modern therapeutic options are available for patients with CVD to reduce the risk of plaque progression or rupture. But how can we identify the patients who would benefit from such a treatment? Diseased arteries and plaques release molecules into the bloodstream. The CISFASC consortium set out to understand how CVD develops and to identify new targets for therapeutic intervention. Therefore, the CISFASC consortium used methods such as mass spectrometry to analyze large numbers of blood and tissue samples from patients at different stages of cardiovascular disease to uncover their molecular composition. CISFAS researchers have employed sophisticated methods to identify new biomarkers which correlate with the severity of vascular damage. While this work is still ongoing, substantial progress has already been made towards identifying molecular targets, and a specialized cardiovascular disease knowledge base is available to support this research. Promising candidates are being tested for their impact on disease progression as we speak. Using the telltale molecules that we hope to find, clinicians in the future will be able to identify patients with unstable plaques. This would allow these patients to receive preventative therapy to interfere with the catastrophic and currently unpredictable events leading to stroke and heart
The
attack.
heart pumps blood to your brain through blood vessels in your neck. These blood vessels, called arteries, branch into even smaller arteries that bring blood to your brain cells. Some of these small arteries join each other to form a loop known as the circle of Willis. The walls of the arteries contain special muscle and elastic layers that help them adapt to the blood pulsing through them. Sometimes, diseases, injuries, or birth defects can cause a weak spot in the wall of the arteries in the circle of Willis. These weak spots usually form where arteries branch. Over time, the pressure of blood flowing through the artery stresses the weak spot further. The constant blood pressure can cause the weak spot to balloon out and form a bulge called a cerebral aneurysm. This cerebral aneurysm is the most common type, called a saccular or berry aneurysm. Over time, the aneurysm may grow and push on nearby brain tissue or nerves. Blood may also leak from the aneurysm. If its wall gets too thin, the aneurysm can burst or rupture and spill high-pressure blood into the space around your brain. The blood presses on your brain tissue and can cause injury to your brain cells. Chemicals in the escaped blood can irritate other brain arteries and cause them to narrow. As a result, your brain can swell, leading to serious brain injury. Common symptoms of a ruptured cerebral aneurysm include sudden severe headache, sometimes called a thunderclap headache, problems with your vision, such as blurred or double vision, nausea and vomiting, a stiff or painful neck, or confusion. An unruptured cerebral aneurysm may not cause symptoms, but large unruptured aneurysms may cause headache and pain near or behind one eye, double or blurred vision, a drooping eyelid, and numbness or weakness on one side of your face.